start with the first case, conundrum of acute liver failure from Department of General Medicine, presented by Dr. B. Sai Vishnu, Junior Resident, moderator Dr. Surya Tejas.
It is like honeycomb, sir, having multiple causes, like riddle, sir. It is derived from Latin word, sir. It has been using from 16th and 17th century.
What you told is a literal meaning. What is their literal meaning is multiple puzzles. Literature and originated word is that is what is from that.
Yes. Coming to presenting complaints, my patient is a 20 years old male presented to hospital with history of fever with chills on and off since 35 days, vomiting since 12 days, abdominal pain, loose stool since 5 days. Going to history of present illness. The patient has been in good health until 35 days prior to admission, when he developed fever high grade associated with chills and rigors and generalized myalgias, associated with nausea and not associated with vomiting, loose stools, any rash. On third day of illness, he consulted a qualified doctor and was prescribed a combination of aceclofenac, thiacloprid, paracetamol, cefixime, and levocetirizine, abiprazole along with domperidone for 3 days. The symptoms improved during the treatment and persisted for 1 day before the patient resumed his daily activities. On day 8 of illness, the patient experienced a resurgence of high-grade fever with chills, increased myalgias, postural dizziness on standing, and noted a dark discoloration of his urine and eyes. On day 10 of illness, the patient revisited the same doctor with these symptoms, where laboratory test was done, negative for Salmonella typhi and paratyphi ONH antigens, and came positive for Plasmodium falciparum and Plasmodium vivax antigen. His total bilirubin during this time was 2.5 mg per deciliter, diet was 1.8. He was diagnosed as malaria and was prescribed intravenous artemether on 50 mg doxycycline paracetamol. The patient went to the clinic on day 10, where he was admitted for 4 days and was treated with intravenous fluids, primaquine and multivitamins. Although the reading sensations and nausea improved, the fever and jaundice persisted during these 4 days, and the patient was discharged on day 13 with some discharge medication with total bilirubin of 2.1 microgram per deciliter. On day 16, he was due to the persistence of alert discoloration of eyes, the total bilirubin was rechecked, where it was 2.5 microgram per deciliter. On day 24, that is 3 weeks after the onset of illness, the patient began herbal supplementation. That is, he used 1 gram powder dissolved in water 3 times per week. He used it for 1 week. After initiation of this powder, he started developing vomiting since 12 days, 2 episodes per day, small quantity, contains food particles, aggravate on food and water intake. There is no relieving factors, non-bilious, non-bloodstained, and non-foul smell. Here is a place where the patient was prescribed the herbal supplementation. At day 30, that is 4 weeks after the initiation of illness, the patient developed abdominal pain and loose stools. Abdominal pain which is insidious in onset, in right upper abdomen and umbilical region, intermittent, dull aching, non-radiating, non-migratory, aggravated with food intake, and there is no relieving factors. Loose stools since 5 days, 2 to 3 episodes per day, which is small quantity, water in consistency, non-foul smelling and non-bloodstream. However, he discontinued the herbal regimen after developing a recurrence of fever, vomiting, abdominal pain, loose stools. On day 36, that is nearly 5 weeks after the illness has been started, the patient presented to our emergency department. The patient was admitted for further evaluation. There is no complaint of itching or any rash over the body, no complaint of loose stools. There is a complaint of loose stools. Blood in the stools, abdominal pain, burning micturition, no complaint of cough, shortness of breath, hemoptysis, hemoptysis, no complaint of chest pain, palpitations, pale edema, no complaint of involuntary movements, involuntary micturition, defecation, loss of consciousness. Here is a timeline of events. During day 1, the patient developed high-grade fever along with chills and rigor. During day 3, he visited the nearby hospital. On day 5, the symptoms subsided with treatment given by the qualified doctor on day 3. In day 8, he has again resurgence of symptoms like alert discoloration of eyes and urine. On day 10, he was diagnosed with malaria and given with medication. On day 13, he was discharged with persistent fever and jaundice. On day 16, the bilirubin was rechecked where it was 2.5. On day 24, the patient was started herbal supplementation, after which the patient was developed vomiting, loose stools, abdominal pain. On day 36, that is nearly 5 weeks after the initial illness, the patient was presented to our emergency department. Here, these are investigations done extended to the hospital, where CBP was normal. LFT shows a bilirubinemia 2.5, mild hyperbilirubinemia, but there is no enzymes was done outside. Limiting the access to show whether it is a hepatocellular or cholestatic, making it as an incomplete evaluation. In fever profile, the Plasmodium vivax and falciparum rapid antigen was positive. and rest vital was negative. Past history. No history of similar complaints in the past. The patient has no significant medical history or known drug allergies. He reported a history of consuming outside food every other day, particularly during the recent flooding event in the area before the onset of illness. He has no recent travel history, no history of blood transfusions, and no history of any toxin intake. Family history. He resides in a crowded area with his family, with his father and mother who had experienced a similar illness characterized by fever and myalgias at the same time and got resolved in 3 days. Personal history. The patient has completed education up to 12th grade and was working in a spare part warehouse. He denied smoking, alcohol, or drug consumption. Take mixed diet. Sleep is normal with reduced appetite. Bowel and bladder habits is normal. General examination. The patient looks ill, but he is completely conscious and oriented with normal BMI. On systemic examination, there is a marked icteris present, and other like pallor, clubbing, lymphadenopathy was absent. At the time of presentation, there is a normal BP, normal saturation with mild tachycardia and tachypnea with a high grade fever of 1 or 2 degrees, with normal random blood sugar of 1 compared to liter. Ongoing systemic examination, when you examine the abdomen, the scaphoid is the abdomen is scaphoid shaped. There is no scars and sinus. Umbilicus is normal inverted. There is no superficial dilated veins over the abdomen. It is soft. Abdominal tenderness is located in the right upper quadrant. Liver span is at normal, that is 10 centimeters. Spleen is palpable, that is just below the left costal margin. There is no free fluid in the abdomen. Also is present. Other system like respiratory system, cardiovascular, and CNS system is normal. We have a provisional diagnosis. We conclude it as malarial hepatopathy, or it is drug-induced liver injury plus acute viral hepatitis. Investigations during our admission in our hospital, the completed picture was normal with the normal electrolytes, normal renal function. CRP shows mildly elevated, suggesting some underlying inflammation is present. Here on day 36, the LFT shows very high, severely hyperbil transaminases, nearly around 3000, with direct hyperbilirubinemia. Albumin is normal. Coagulation profile INR is 1.9, and in urine positive for bilirubin. Fever panel in our hospital was negative for dengue, plasmodium, and chikungunya, and virals were also negative.
This is frontal chest radiograph. Trachea is in midline. Cardiac shadows are normal limits. Bilateral lung fields appear clear. Both costophrenic angles appear. Both domes of diaphragm are well outlined.
This is a 12-lead ECD showing a rate of 76 beats per minute with regular rhythm, and axis is normal. On ultrasound abdominal pelvis, there is a splenomegaly present of 14 centimeters, suggesting its correlation with our clinical examination. Treatment. On day 36, that is on day of admission in our hospital, the patient was treated with IV fluids with multivitamin injection, artesunate, vitamin K, ondansetron, deoxycholic acid, and other supportive medications like N-acetylcysteine, vitamin E, and paracetamol. On date of hospital admission, the patient is febrile and vomiting is resolved. Continue same line of management. The serology for hepatitis C is come to positive, and with hepatitis C and malaria for parasitic QBC was negative. 2D was normal. On day 38, the patient was symptomatically improved. Continue same line of management. Gastroenterologist referral was taken in view of acute viral hepatitis C and hyperbilirubinemia. Start out to continue same medication along with supportive medication like Feveride, and follow up with the LFT and the PTN reports. In successive days, we have continued the same treatment. The patient was got symptomatically improved. These are laboratory investigations during course of illness. The CBP was normal during successive days with normal morphology in the smear. LFT is done in successive days, initially showing very severe transaminases, that is around 3000, with the direct hyperbilirubinemia and coagulopathy present, that is INR of 1.9. On gradual successive days, it has been reduced to near normal. These are the graphs showing that there is a decrease in terms of transaminases from around 3000 to 400. Blood culture. There is no bacterial growth after 48 hours of aerobic incubation. In CUV show there is a positive for bilirubin, and there is in microscopy there is no infections present. Patient is discharged in febrile state with stable vitals with normal bilirubin of 4.3. That is direct pattern, and enzymes SGOT and SGPT of 98 and 426 and ALP of 355. Here our diagnosis causes like one is our plasmodium falciparum, which causes an insult, and second is drug-induced liver injury, and third is because of either herbal toxicity, and fourth is hepatitis A. Around all these four causes an cumulative insult on the liver. Our final diagnosis is acute viral hepatitis C, and drug-induced liver injury secondary to herbal supplementation, and clinical malaria.
With
Follow. The patient was febrile and symptoms got subsided. On day 53 and 60, the total bilirubin 1.6 normal. Enzymes came to near normal CDP. This case we have also published in Annals of African Medicine.
తెలుగులో ఏమంటారు? తికమక పెట్టే కేసు, తికమక పట్టుతాం. ఓకే, swallow. What can you swallow? You cannot swallow a man. You pride only you swallow. Something like that. Okay? You eat. You also enjoy that. You will never forget what you eat.
any questions, comments, compliment? Questions, comments, compliments.
Smear positive in our center is the malaria smear positive. Sir, smear for parasite is no.
In our hospital is negative.
In our hospital
He
it
has
is
come, he has taken up the treatment. It is negative.
but only antigen is positive. Sir, outside also.
Outside is antigen positive.
It's a rapid test.
Rapid test. That's why they are given treatment.
But
Yeah,
even
we are not.
Resident Medicine, Moderator Dr. K. Vamsi Krishna, Professor, Department of Neurology. Department of Neurology. 35-year-old woman was presented to neurology OPD on 20th August 2025 with chief complaint of headache, blurring of vision, vomiting since 5 days. History of presenting illness. Patient was a known case of acute promyelocytic leukemia diagnosed in July 2025 at outside hospital. Patient was started on chemotherapy on tablet all-trans retinoic acid plus injection arsenic trioxide. During the course of treatment, after 1 month duration of chemotherapy, patient developed current symptoms. MRI was done. Then patient was referred to Department of Neurology in Dr.pinnamaneni for further evaluation and management. She came with a chief complaint of headache since 5 days, sudden in onset, unilateral, right-sided, continuous and dull type, non-radiating, not associated with photophobia, phonophobia, aura, and no weakness of upper limb and lower limb. Complaining of blurring of vision since 5 days, sudden in onset, bilateral, not associated with pain, redness or double vision. Complaining of vomiting since 5 days, sudden in onset, 2 to 3 episodes per day, food particles as a content, non-bilious, not associated with nausea, abdominal pain or loose stools. There is no history of loss of consciousness, involuntary movements, no history of eye pain, redness of eye, pain on eye movements, no history of flashes of light, double vision, no history of shortness of breath, cough, wheezing, and no history of chest pain, palpitations, and no fever and neck stiffness. Past history, she is not a known case of hypertension, diabetes, coronary artery disease, cerebrovascular accident, PTB, bronchial asthma, CKD or CLD. Personal history, normal sleep and appetite, she takes mixed diet, regular bowel and bladder habits, no addictions, no known food, drug, environmental allergies. Family history nil significant. Menstrual history, regular cycles, 5 by 28 day cycle, not associated with clots. Menorrhagia present changing 4 to 5 pads per day since 3 months. No dysmenorrhea. General examination, patient is conscious, coherent, well oriented to time, place, person, moderately built and nourished. BMI was 22 kg per meter square. Pallor present, no icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Vitals at the time of presentation, BP was 110 by 80 millimeters mercury, pulse rate 86 beats per minute, respiratory rate 14 cycles per minute, temperature 98 degree Fahrenheit, saturation was 99% at room air, GRPS 190 milligram per deciliter. CNS examination, she is a right-handed person, education 10th standard, higher mental functions were normal, recent immediate remote memory was normal, MMSE was 30/30, speech was normal. Cranial nerve examination, olfactory, she is able to perceive smell, optic nerve, visual acuity, visual field, color vision was normal in both eyes. Fundus examination, right, both eyes showing optic disc blurring of disc margin, elevation of the disc, obliteration of the blood vessels, leaving the disc, splinter hemorrhages were present. Blood vessel attenuation was present, macula was normal, impression both eyes showing grade 4 papillary edema. 346 cranial nerve examination, on extraocular movements there is abduction defect present in both eyes. Eyelid, position of eyeball and pupils were normal, nystagmus was absent. On right case, there is abduction deficit in the right eye. On left case, there is abduction deficit in the left eye. Remaining extraocular movements were normal. No, sir. Trigeminal nerve, sensory and motor components were normal. Jaw reflex was present. Facial nerve, sensory and motor components were normal. 8, 9, 10, 11 cranial nerve functions were normal. Hypoglossal nerve function was normal. Motor system examination, attitude normal, bulk bilateral symmetrical, tone normal tone in both upper limb and lower limb. Power 5/5 in all limbs. Reflexes, superficial reflexes were present, deep reflexes were present. Sensory system, primary sensations were present, cortical sensations were present, Romberg's test negative. Cerebellar examination, cerebellar function tests were normal, no meningeal signs, no spine or cranial deformities. Other system examinations were normal. Provisional diagnosis, headache plus bilateral abducens nerve palsy under evaluation, query, idiopathic intracranial hypertension or cerebral venous sinus thrombosis. She is a known case of acute promyelocytic leukemia on chemotherapy, all trans retinoic acid and arsenic dioxide. ECG was normal. Chest X-ray.
This is frontal chest radiograph. Trachea is in midline. Cardiac shadow appears within normal limits. Bilateral lung fields appear clear. Both domes of diaphragm well outlined. Both costophrenic angles are free.
CBP at the time of presentation, HB was 9.4. Total WBC counts were 8,000. Platelets were 6,29,000. Peripherals near normocytic normochromic anemia with reactive thrombocytosis. RFTs were normal. Coagulation profile was normal. HbA1c, TSH were normal. Lipid profile was normal. Serum electrolytes were within normal limits. LFTs were normal and CUE shows normal. Ultrasound abdomen pelvis, no significant sonological abnormality detected. 2D echo, no left ventricle regional wall motion abnormality, no LV or normal LV RV function EF 60%, decreased diastolic compliance, no MR, AR, TR, PAH, no PE, clot or vegetation, IVC normal and collapsing. MRI brain.
What is the longest cranial nerve?
Sixth nerve.
The answer is obvious. Otherwise, I wouldn't have asked. What is it?
Sixth cranial.
What is the longest cranial nerve?
Intracranial
Abducens. You only told. Abducens.
Abducens.
How many of you know that? And why is bilateral? How did it happen? Bilateral?
Bilateral abduction deficit is present.
Michael.
Bilateral abduction deficit is present in both eyes.
So he's asking
Maybe
why.
due to raised ICT, sir. Due to raised intracranial pressure.
We'll talk it a little later. Now, why LP was not done? Lumbar puncture for CSF analysis.
Because there is no fever, no meningeal signs.
When a patient is having a treatment for an acute myeloid leukemia and presented with the signs of raised intracranial tension, whether there is inflammatory signs or infectious signs, we should do an LP to exclude a meningeal component of leukemia, which is not responsive to treatment.
Because this patient,
Not say it is meningeal here. It is not meningeal leukemia.
sir, when we didn't consider because this patient on treatment with ATRA, like presented with raised recipe features. So we consider whether it is due to the primary disease or due to drug. So, but to consider primary disease, that patient is in remission, all our blood parameters.
I
Yeah.
do agree. A patient with a beautiful leukemia, that is promyelocytic, which has a very good rewarding prognosis of all the AMLs, am I right, sir? And this is so rewarding, one tablet for a long time and then everything remission occurred. But has the hematologist has pronounced a complete remission by doing a CSR. In all acute leukemias, CSF should be done, either examined or meningeal component by MRI sequence to call it as a complete leukemia, complete remission along with the bone marrow. If it is that so, I don't ask. But if it is not done, CSF should be done. Why? Because we miss the peripheral smear is normal and even including bone marrow says pathologist remission. But in CSF, even one promyelocyte is sufficient for you to call it is a meningeal component which still preserved, wherein which the treatment is. 2. In AML, acute myeloid promyelocytic, I don't expect a treatment-related complication. Why? Normally, other myeloid leukemias, you give L-asparginase and other things which can produce venous sinus thrombosis and all these things. And with this drug, we will discuss little later.
Even that ATRA is reported to cause.
This is the images of MRI brain. Here we can see an axial DWI image in which we can see a subtle hyperintensity in the right high frontal white matter. And next slide please. On the corresponding T2 flare images also we can see hyperintensity with adjacent mild cortical edema. In the screening MRD images, we can see that the anterior aspect of this superior sagittal sinus appears narrowed in caliber with with the minimal flow void. We can see that in both the images, and this might be due to partial thrombus and features are in favor of venous thrombosis.
MRI brain report. Subtle hyperintense area seen in right high frontal region on DW-weighted image with adjacent mild cortical thickening and swelling could be any venous infarct or focal meningoencephalitis. And mild diffuse cerebral atrophy with early small vessel ischemic disease. Partial empty cell are seen, bilateral optic nerve sheaths appear dilated, signs of raised intracranial pressure. MR venogram screening shows anterior aspect of superior sagittal sinus is narrowed in caliber with partial loss of flow void, likely indicates partial thrombus. Carotid Doppler, no significant abnormality detected in bilateral carotid arterial system. Treatment given, IV fluids 1 pint NS with MBI, tablet estrojolamide 250 mg 12th hourly, tablet apixaban 5 mg 12th hourly, tablet Pantop and capsule multivitamin. Final diagnosis, cerebral venous sinus thrombosis. She is a known case of acute promyelocytic leukemia on chemotherapy, ultra and arsenic trioxide.
Diffusion with restriction is there, so acute restriction. Which ones are there? Because they are treated for this also mechanism of action fast ఉంటుంది సార్ Apixaban there is no need for bridging therapy.
Comment on the drug, the leukemia and complication. The complication is related to treatment of leukemia, complication is related to leukemia, complication is unrelated to both. Let you clarify with this.
Because we thought of this patient, CSVT might be due to this drug only because patient after starting the treatment with this drug, when she had a symptoms. So it could be possible, we can say it is due to that drug, sir. Because even the acute myeloid leukemia can have thrombosis tendency, but more of a like hemorrhagic complication with thrombocytopenia in AVC. But we can't say completely, sir. But based on the after treatment patient presenting with the features of rise CT, so we consider that it might be due to this drug, sir.
Why I asked that question is, a promyelocytic component has an enormous amount of liberation of the things, particularly lysosomuria, which is very common in promyelocytic leukemia, unlike myelocytic and pre. That's why you will see more of a polar cells and that cytoplasm is gone out in the peripheral sphere. That lysosomuria is responsible for two important things. One is the leukemic complications of the kidney acute. The two, the lysosomes activate coagulation cascade when the concentration is above certain levels, which precipitate the thrombus, which will not be evident in acute phase because it is more preoccupied with the treatment of the latter one after the other slowly evident. Because when there is a bilateral papilledema of that magnitude, the treatment duration is how much? 4 months, 6 months in this remission.
He's still going on, sir, chemotherapy.
5
months.
That's what is important. Probably it may be a part of the spectrum of promyelocytic with aggravated coagulation cascade, nothing. Are there any series in which transretinoic acid related coagulopathies? Verify this, sir.
Yes, sir.
What is ATO?
Arsenic trioxide.
Arsenic trioxide.
Why I am asking that? Is it arsenic trioxide or ATA? ATRA is responsible, which has associated with more epicoagulation.
ATRA is more.
In addition to the primary disease.
ATRA is more.
ATRA is more, sir.
More, sir.
ATRA is.
Why?
It can have prothrombotic.
We used to see before the ATRA, L-asparginase group of relations, lot of venous complications. ATRA is a little lesser than that. ATO is some other complications.
It's more of a peripheral, sir. Peripheral.
It's a case because when the leukemia is under remission, there won't be any coagulation activity, procoagulant. But procoagulant activity is high in promyelocytic leukemia before remission. At that time, you might have gone for complication and that.
But MRI looks like an acute, so that's why we thought of.
Sinus thrombosis is a propagating component after the other things, once initiated. Now the question for a tachyphylaxis. What is the pressure you have managed? For that at least you have to do an LP. And then the pressure will dictate quantum whether neurosurgeon can be involved in it or not. A wonderful case. You have to present it and publish it.
Follow-up. After 1 month, patient symptoms improved. No complaints of vomitings, headache, blurring of vision. On examination, no signs of raised intracranial pressure. Both eyes, extraocular movements were normal.
Wonderful. What it tells to you? When he was given an anticoagulant of 1 month, he came back to normal. What it tells to you? That's the question here. It is not a perpetuating disease. It is once for all occurred. And the thrombus is getting organized. There is no continuity of pathogenetic mechanism either of leukemia or otherwise. And the thrombus is recanalized and everything come out, which is a very 1/3 of established prognostic component. Usually it will not happen like that. Comments from ICT of SCVT and surgical intervention.
So in general, surgery for CSVT, surgical cerebral central sinus venous thrombosis cases, it is the last option because already the draining veins, intracranial draining veins are blocked. By doing craniotomy, you are cutting the scalp draining veins also. So it will further block the venous drainage. So unless it is a last effort, we should try to manage conservatively.
Therefore, if it is not responding to conservative treatment of anticoagulants after 6 months of review, still papilledema is present and blind spot is increasing, then you call Dr. Srinivas for intervention.
And then in this case, I don't see there is any such problem. The endovascular,
do it for
venous endovascular,
post-meningeal tuberculous meningitis, you do a shunt like that. In this case,
In this case, endovascular venous thrombectomies are the recent advances. Those are the options.
Good afternoon, everyone. I am Dr. Soumya, second year resident from the Department of Anesthesiology. Today I will be presenting on the topic balancing risk for ASA grade 4 patients using regional anesthesia strategies. So ASA grade 4 patients are those with severe systemic disease that are constant threat to life. They have a mortality of around 7.8 to 25%. Our case 1 is a 48-year-old obese male with long-standing hypertension since 10 years and with ischemic heart disease with prior cardiac arrest with severe LV dysfunction, whose ejection fraction is 30%. And he is posted for open reduction and internal fixation of right distal tibial fracture with high perioperative cardiac risk. His major comorbidities are long-standing hypertension, ischemic heart disease, and he had cardiac arrest 4 months back and return of spontaneous circulation occurred after 2 cycles of CPR. He had severe LV dysfunction with EF 30% and dilated LV, global hypokinesia and mild concentric LVH. His clinical status, the vitals are stable with BP of 130/80.
Point must summarize all the major comorbidity. Any cardiology resident? In 1-2 words, that thing should be commented. That is low ejection fraction, left ventricular dysfunction, or otherwise our HOD itself is present, no resident. Therefore, it is not common.
As far as cardiology is concerned, see, acute ischemic syndrome less than 6 months, an acute MI, ST elevation, non-ST elevation carries a high risk. First importantly, age more than 70 years, so then it is a high risk group. See, irrespective whether they have symptoms or not, all those things. And the third important factor is the patient who has an LV dysfunction or has heart failure. If heart failure is uncontrolled, is risky, but once it's controlled, the risk comes down. And the fourth important is arrhythmias and conduction blocks. And the other important law, finally come the metabolic factors like blood sugar more than 200 milligrams per cent, creatinine more than 2 milligrams per cent, and electrolyte imbalance. These are the major risk factors for an anesthesia. Any patient, not only cardiology, cardiology have enumerated 4 patients. So this patient comes at high risk only, but if the heart failure is controlled, the risk comes down. But still, ejection fraction of 30% means definitely you may have any complication during anesthesia, especially general anesthesia, and spinal is very dangerous. So among the regional, you can select an epidural or a local regional nerve block and those things.
Thank you.
And his effort tolerance is greater than 4 metabolic equivalents. He has anticipated difficult airway due to obesity and avulsion. And our case, second case is a 67-year-old male patient who is diabetic, hypertensive, chronic kidney disease stage 5 on regular hemodialysis from 2.5 years with history of CVA 7 years back. Came to OPD with complaints of right knee pain since 2 months associated with swelling of the knee joint after history of fall on right leg 2 months back. His medical history is the patient is a known case of hypertension since 20 years using tablet bisoprolol 5 mg OD and type 2 diabetes mellitus since 20 years, currently on injection human actrapid. CKD stage 5 on maintenance hemodialysis since thrice weekly since 2.5 years. He has an AV fistula on left forearm and the last dialysis was done 2 days prior to surgery. Other drug history was he is using tablet aspirin 150 mg OD, tablet nitroglycerin 2.6 mg, tablet soda bicarb 500 mg, tablet torsemide 10 mg, tablet midodrine hydrochloride 2.5 mg SOS. His vitals are pulse rate is 70 beats per minute, regularly irregular. BP is 130/70 mmHg. SpO2 is 97% at room A. Respiratory rate is 23 cycles per minute. On examination, patient is conscious, coherent and cooperative. On CVS examination, S1 and S2 is heard with no murmurs. On respiratory system examination, bilateral air entry is present. Breath sounds are decreased in left mid-axillary, interscapular, in infrascapular areas with bilateral basal crepitations. On GIT examination, diffuse tenderness present in all quadrants of abdomen. CNS, no focal neurological deficits are present. Spine is midline and intervertebral spaces are palpable. On airway examination, which is done in supine position, patient has short neck and double chin, and he has Malampati grade 4, where only the hard palate is visible, the soft palate is not visible. Extremities examination, AV fistula is present on left arm and swollen right knee with restricted movement system. Diffuse tenderness is present over both lower limbs. Investigations. His HB is 11.5 gram per deciliter, PCV is 37%, platelets are 2.1 lakh, PT is 15.2 seconds, INR is 1.3, urea is 76 mg per deciliter, creat is 4 mg per deciliter, electrolytes are normal, RBS is 208 mg per deciliter, HbA1c is 7.1%. His echo showed atrial flutter during study, EF is 40%, RVSP is 35 mmHg, and it also showed global hypokinesia of left ventricle, mild TR with PAH and LV dysfunction. ECG is showing atrial flutter in lead 2, 3 and AVF with T inversions in 2, 3 AVF and V2 to V6. Chest X-ray.
Frontal chest radiograph. Trachea is in midline. Cardiac shallow appears to be enlarged. Bilateral lung fields appears to be clear to the extent, except some mild bronchovascular markings. Both domes of diaphragm are well outlined. CP angles are clear.
What are the chambers and
Ross, sir. Ross.
Diagnosis is infective or amyloid arthropathy of right knee, and the surgical plan is arthrotomy, debridement and synovectomy of right knee. The chosen technique of anesthesia is executed by femoral and popliteal nerve block under ultrasound guidance. GA general anesthesia backup and difficult airway guard is kept on standby. The choice of anesthesia, we have preferred combined femoral plus popliteal block over general and spinal anesthesia. It's because general anesthesia has advantages of rapid onset, but the disadvantages in this case is the patient has an anticipated difficult airway with reduced ejection fraction, and he also has arrhythmias with poor renal clearance, and there is risk of post-op ventilation. So it is not suitable in this patient. And uraxial anesthesia, it is not preferred because the patient is a CKD patient with platelet dysfunction, and there is high risk of spinal hematoma formation with severe hypotension risk. So it is contraindicated. Combined femoral and popliteal block, it is suitable because it has complete anesthesia for knee joint, stable hemodynamics and avoids D or neuraxial risks. So it is the chosen technique. Femoral nerve block. Patient in supine position, legs slightly abducted and externally rotated. High frequency linear ultrasound transducer probe is placed at the inguinal crease in transverse orientation. Femoral nerve is identified as an oval structure, hyperechoic lateral to femoral artery, which is an anechoic and pulsatile structure. 10 ml of local anesthetic is
You gave the block at the level of femoral triangle opening or little lower or middle?
At the inguinal crease, sir. No, sir. Operator.
Okay.
Popliteal nerve block is also given. The position of the patient is kept in left lateral position with operative leg on the uppermost side and knee slightly flexed. Ultrasound transducer probe is placed transversely 7 to 10 centimeters above popliteal crease. Popliteal artery and vein are identified. Sciatic nerve is identified lateral to the popliteal artery. The probe is traced proximally where sciatic nerve is seen before bifurcating into tibial and common peroneal nerve. The needle tip is inserted in plane lateral to medial approach. Advance the needle tip to close to sciatic nerve. Aspiration is done to rule out intravascular injection. 10 ml of local anesthetic is spread around the nerve. Discussion. Both cases are high-risk cases of ASA grade 4, so they are not suitable for general anesthesia or the epidural or spinal techniques. Pre-operatively, patients are optimized by pre-op dialysis, electrolyte correction, hemoglobin optimization and blood pressure control. Anticipated difficult airway and GA backup strategy was there. Intraoperatively, hemodynamic instability is anticipated and arrhythmias and fluid restriction were also anticipated. ICU is alerted before surgery and patients transferred to surgical ICU after surgery. Post-op dialysis is planned when initiated. Thank you.
Surgeons and other doctors, everyone. See, what are the problems of anesthesia like that? So actually, if you take Miller textbook, initially he has written pre-op to assessment, cardiac risk, all those things very nicely written. So last 2 weeks back, I went to library. I saw it so long back, and then now it's long colored photographs. Everything is very nicely written.
And leprosy presented by Dr. Omkar, moderator Dr. Shweta Chowdhury.
Today I will be presenting the case series of facial leprosy. Introduction. Leprosy is a chronic granulomatous disease caused by Mycobacterium leprae. Leprosy has varied presentations, particularly on the face, where lesions may be subtle or atypical. Facial lesions are challenging due to preserved sensation and overlapping morphology. We are presenting 3 facial Hansen's cases highlighting these variations and key diagnostic clues. Case 1. Chief complaints: a 44-year-old man presented with solid red elevated lesion over the left side of the forehead and left eyebrow since 1 year. History of present illness. Patient was apparently normal 1 year ago when he noticed a peanut-sized solid elevated lesion over the left side of the forehead. The lesion gradually enlarged over 1 year and extended to involve the left eyebrow region. The swelling has been slowly progressive and asymptomatic with no pain, itching or discharge. No history of trauma, insect bite, fever, drug intake, numbness and weakness. Past history, no significant similar complaints in the past, not a known case of diabetes, hypertension, pulmonary tuberculosis, CAD or CVD. Personal history and family history is insignificant. General examination is normal in this case. Systemic examination is also normal in this case. Mucocutaneous examination, a 5 into 5 centimeters erythematous block over the left side of the forehead and extending to medial 1/3 of the left eyebrow. A similar smaller block noted over the medial aspect of the right eyebrow, which is considered as satellite lesion, is noted. Both blocks have well to ill-defined margins. Madarosis involving the medial 1/3 of the left eyebrow is. In sensory examination, touch, pain and temperature sensations were intact over both facial lesions. In peripheral examination, supraorbital nerve is thickened and is non-tender on both right and left side. Significantly, the left side supraorbital nerve is more thickened compared to right side. Corneal reflex, conjunctival reflex is intact on both sides, along with facial nerve is normal, with preserved sensations. With this, my provisional diagnosis is borderline tuberculoid Hansen's, and other possible differentials include sarcoidosis, pseudolymphoma, and granuloma facial. Other investigations like skin smear were performed along with normal blood investigations, and these are my histopathology images.
Over the patch which you mentioned that as a little papular lesion, what is your examination of sensations? Around the patch, inside the patch. Have you done it?
Yes, sir. On the patch, sir. On the patch, intact sensations, sir.
What sensations you have done?
Touch, pain and temperature sensations, sir. Touch includes fine touch and both crude touch, sir.
What temperature you have done? That my
both
question.
Hot and cold sensation.
What are the degrees of elevation of temperature which you have done?
For cold, 20 to 25 degrees water is taken, sir. For
if
hot,
the test tube is wet or the test tube is dry?
Dry, sir.
Why I am asking that question? Pain may be preserved, but temperature will be lost. Then what you call that? Pain is present, temperature is lost. What you call that? That is what is that? That is one of the important neurological phenomena. That is dissociated sensory loss in truest neurological sense occurs in leprosy, but no other condition. And rare is your syringomania. A focal dermatomal dissociated sensory loss if you manifest. I am sure pain is present, but temperature I will add little amount of hesitancy because residents rarely examine temperature anywhere, whether it is GM neurology or otherwise also. But I don't know, it's a general comment, not sarcastic. That itself is a sign. Dissociated sensory loss will never occur in any other condition. Peripheral nerve lesion is leprosy. Why we will discuss that?
Histopathology images.
This is a focused photomicrograph of a HND stained section in low power view showing the skin lined by keratinized stratified squamous epithelium, and the epidermis is thinned out due to loss of reed ridges, and other skin appendages such as hair follicles are identified. And this is a perivascular granulomatous lesion showing multiple numerous epidermoid histiocytes can be seen, and a good number of lymphocytes surrounding in and out the granulomatous lesion, and few multinucleated giant cells are appreciated. So features are in favor of borderline tuberculoid leprosy.
The history is not given to you. The slide is given to you by your pathology professor. How do you say it is a leprosy granulomatosis? Can I ask that question? You are a resident of pathology. No history. Can you say it is a leprous granuloma or can you say it is a tuberculous granuloma? I am at liberty to ask that question with the permission of your faculty.
It is a tubercular granuloma because in lepromatous granulomas are
not... The granuloma is Hansen's granuloma or tuberculous. I am not asking about tuberculoid and other things. We will come to it little later.
Necrosis is not.
You have told the answer, that's why I asked the question. But you don't know that is the answer for the question.
Caseating necrosis is present.
Multinucleated giant histiocytic macrophagic cells are hallmark not of tuberculosis but of ఇందులో కంటే ఎక్కువ ఉందా ఇందులో ఇంకేమైనా ఫ్యాక్టర్ ఉంటే మీరు చెప్పకపోతే చెప్పండి సార్
Caseating necrosis.
రెండు మళ్ళీ ఆన్సర్ చెప్పాలి నేను అడిగినప్పుడు క్వశ్చన్. Therefore, without history, you should make it a comment that it is a Hansen's granuloma. అంతే కదండి? What it is? Tuberculoid and lepromatous is by their clinical judgment and a little amount of pathological judgment. Okay. Because we were trained in the century of leprosy dominance, seeing thousands of cases.
This is the histopathology report. With these clinical findings like erythematous block over the forehead and supraorbital nerve thickening along with significant histological report, we finally arrive at a final diagnosis like borderline tuberculoid Hansen's disease, and the treatment of MBMDD is started for this patient. Coming to second case, chief complaints, a 21-year-old male patient presented with a symptomatic solid red elevated lesion over the right side of the forehead since 1 month. History of present illness. Patient was apparently normal 1 month ago when he first noticed a solid red elevated lesion over the right side of the forehead, which is gradually progressive in nature. Lesion was asymptomatic with no itching, pain, burning or discharge. No history of trauma, insect bite, fever, drug intake or weakness. Patient took treatment on and off with tab hydroxyzine 25 mg along with betamethasone cream for about 2 weeks with no significant improvement. No significant past personal or family history in this case. General examination was also normal along with systemic examination. Coming to mucocutaneous examination, a single erythematous block involving the right side of the forehead, right eyebrow, extending onto the root of the nose. Well-defined midline margin with gradual peripheral fading towards the right temporal area. On full body examination, a similar lesion of size 4 into 4 centimeters, noted over dorsal aspect of the left forearm. Sensory examination. Touch and pain were decreased over the left forearm lesion and normal over the forehead. Temperature were normal both facial and extremity lesions. In peripheral nerve examination, no peripheral nerves were thickened or tenderness is noted. Differentials for this case is borderline tuberculoid Hansen's, sarcoidosis, pseudolymphoma and granuloma facial. In investigations, slit skin smear was negative and blood investigations were within the normal limits. This is the histopathology image.
This is a focused photomicrograph of a HND stained image. Here we could see the loss of reed ridges in the epidermis. So epidermis is thinned out here. Next image. Here we can appreciate the loss of reed ridges very well, and within the superficial or dermis or papillary dermis we can appreciate good amount of granulomas and well-formed granulomas. This is the high power view of the same granuloma showing a good amount of epithelioid cells and occasional multinucleated giant cells and good number of lymphocytes in and around the granulomatous lesion. This is also in favor of borderline tuberculoid leprosy.
This is the histopathology report with the clinical images like erythematous plaque over the forehead and similar lesion over the left dorsal aspect of the forearm and decreased sensations along with histopathology changes. We conclude it as a borderline tuberculoid Hansen's. This patient also MBMDT is started. Third case, chief complaints. A 30-year-old woman presented with asymptomatic hypopigmented flat lesion below the right side of the lower lip since 4 months. History of present illness. Patient was apparently normal 4 months ago when she noticed a small hypopigmented flat lesion just below the right side of the lower lip. The lesion gradually increased to its present size. The lesion has been completely asymptomatic without pain, itching, burning or discharge. No history of fever, trauma, insect bite, drug intake or tingling or numbness, weakness. Past history, personal history, family history is insignificant. General examination is also normal along with systemic examination. In mucocutaneous examination, a well to ill-defined hypopigmented patch extending from below the right lower lip onto right mandibular area and right cheek with mild central erythema is noted. In sensory examination, touch, pain and temperature were intact over the facial lesion. In peripheral nerve examination, dermal nerve along the mandibular margin of the lesion was thickened and is non-tender on the right side of the face. This case differentials are borderline tuberculoid Hansen's and pre-vitiligo post-inflammatory hypopigmentation. Investigations like slit skin smear was negative and along with blood investigations were within the normal limits. This is the histopathology image.
This is a focused photomicrograph of a HND stained section in the low power showing the skin lined by keratinized stratified squamous epithelium and loss of reed ridges identified. And in the papillary dermis itself we can appreciate numerous granulomas. Next image. And this is the high power view of granulomas showing Langhans type giant cells all over, and good number of lymphocytes are also seen in and around the granulomatous lesion. So these histological features are in favor of borderline tuberculoid leprosy.
This is the histopathology report with clinical images like hypopigmented facial patch along with the thickened dermal nerve and significant histopathology findings. We conclude it as a borderline tuberculoid Hansen's disease. For this patient also MBMDT started. Coming to discussion, India's leprosy prevalence remains 0.5 per 10,000 population with several districts still crossing 1 per 10,000 population showing ongoing local hotspots. India accounts for more than 50% of global leprosy cases and persistent high endemic pockets make sporadic cases still common. Facial skin is cooler and superficial, making it a preferential site for Mycobacterium leprae proliferation. Early recognition, careful nerve examination and timely MDT are critical to prevent deformity and disability.
All are not correct. The last sentence should be repeated by high index of suspicion preceding the recognition. Without an index of suspicion, you never ever diagnose a borderline tuberculoid or tuberculoid. It is easy to diagnose the rest of the thing. Unless, as long as you practice any erythematous and any loss of hair, unilateral partial medarosis, unless otherwise proved, is leprosy in India. Unilateral non-recovering facial segmental facial paralysis, only eyebrows, is leprosy unless proved otherwise. Nothing, you have to take a bath, that's all. That's a dictum. Therefore, index of suspicion for physician, high index of suspicion for every department of dermatology to diagnose leprosy because it is a treatable.
For all departments?
For all departments, physician for trait. But it should be there for all the other departments in such cases. Because India is the capital of even now.
So I would like to give you all of you an interesting feedback from pathology. I think in the last couple of years, we have not seen even a single case of lepromatous leprosy.
Yeah. What is the reason?
So probably epidemiological aspect of the disease. Our department of dermatopathology also should give their feedback, because whatever we are seeing are more or less borderline tuberculoid.
A wonderful point,
So
observation.
probably the incidence or prevalence of lepromatous leprosy has been reduced significantly. Because nowadays we are not able to find a proper control block also.
I will tell the reason about this. In the last century, when it is very pandemically prevalent in an endemic fashion, we had all these spectral disease of polar extremities of tuberculosis and lepromatous seen everywhere and other. With the advent of leprosy control program and contain program, whatever it is, very virulently done it. In fact, the bacillary component of lepromatous is eliminated slowly, and everything is applied. Now, the reins are not tightened yet but loosened. Now again, what I'm cautioning already discussed with our neurologist, this is an indicator that you are going to get leprosy in another 1.5 decades in school children much faster. This should make a light and impact for the people of controlling authorities to contain them. Otherwise, this is the first step for a borderline to go to a full-blown tuberculosis to go into a lepromatous, not in the same individual but therefore 1.5 decades time is left off for you to contain and control and eliminate. It is not infective, but when it breaks beyond certain limits with every day in and day out dietary immunosuppression, drug immunosuppression, disease immunosuppression, no matter of a time the father and mother diabetic will become something and then they will transmit everywhere. Slowly, that's why given 15 years of time. Your question should be validly taken by epidemiological people, LL, particularly the Department of DL. Should be. Thank you, wonderful. Again, or?
Challenges faced in the diagnosis of facial leprosy. That is tuberculoid variety. Rich sensory innervation causes early lesions to retain sensation and delay in diagnosis. Facial blocks can appear subtle or non-specific, often confused with dermatitis, sarcoidosis or discoid lupus erythematosus or fungal infections. Solitary or atypical lesions on the face often require biopsy for confirmation. Topical steroid use on the lesion often alters its morphology, masking classical features. Slit skin smear and fight for aqua stain are often negative in tuberculoid variety. Features favoring the diagnosis of Hansen's disease in our cases were: in case 1, supraorbital nerve thickening suggestive of focal nerve involvement in Hansen's disease. In case 2, complete body examination revealed an unnoticed forearm block with sensory loss, fulfilling a cardinal sign of Hansen's disease. In case 3, dermal nerve thickening along the margin of the lesion, supporting a diagnosis within the Hansen spectrum. All the cases had epithelioid granulomas in perineurovascular and periadnexal distribution, which is specific for Hansen's disease. Granulomatous infiltrate follow the path of the nerve it is attacking, giving a distinctive linear shape, that is serpentine. Facial involvement is seen in the form of madarosis, facial nodules, saddle nose deformity, Buddha's ears in lepromatous leprosy, also known as leonine facies. However, there is extensive body involvement, bilateral peripheral nerve thickening, slit skin smear, and fight for aqua positivity helps in diagnosis, which is not the case in facial tuberculoid leprosy. We present this case series to highlight isolated facial lesions as a potential diagnostic pitfall and to improve the timely recognition by physician. High index of suspicion is needed, especially in Indian scenarios.
He had alleged history of intake of about 100 ml of 20% chlorpyrifos with alcohol at his home at 11 p.m. and presented to the outside hospital the next day with vomitings. Emergency intubation was done in the outside hospital in view of poor GCS
After 7 days of stay in the outside hospital, tracheostomy was done. He got discharged from outside hospital due to financial constraints. He presented to our hospital with tracheostomy tube in situ.
You have to comment at the end, the first para. Yes. He has taken OP poisoning, that is arterophosphorus with alcohol. What is its outcome at the end? You try to answer, even if I don't put the question.
Combination of alcohol and arterophosphorus. More dangerous.
No, sir. With intention. Yes, sir. No complaint of fever, cough, cold, chest pain, palpitations, wheeze. No complaint of abdominal pain, nausea, vomitings or loose stools. No complaint of headache, involuntary movements of limbs. No complaint of burning micturition, increased or decreased frequency of micturition. Past history, not a known case of diabetes, hypertension, CVA, CAD, CKD, asthma, epilepsy, CLD, PTB or thyroid. No history of blood transfusions or previous surgeries. Personal history, it takes mixed diet, regular bowel habits, regular bladder habits, normal sleep and appetite, occasional alcoholic since 20 years, smoker since 30 years, pack years 30. Vitals at the time of admission into our hospital, BP 130/90 mmHg, pulse rate 79 beats per minute, respiratory rate 20 cycles per minute, temperature 98.6 degree Fahrenheit, saturation 88% on room air, 98% with 4 liters O2. GRBS 110 mg per dl, GCS E4 VT M6. General examination, patient is conscious, coherent, obeying commands, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. Systemic examination, CVS S1, S2 heard, no murmurs, RS bilateral normal vesicular breath sounds heard, per abdomen soft non-tender bowel sounds heard, CNS no focal neurological, GCS E4 VT M6. Provisional diagnosis, alleged consumption of 20% chlorpyrifos organophosphorus compound about 100 ml with intention of self-harm, known smoker and alcoholic. This is chest X-ray at the time of presentation.
This is a frontal chest radiograph. Patient is in rotation, cardiac shadow within normal limits, and mild widening of vascular pedicle noted due to the pulmonary congestion. Rest of the lung fields are clear to the visualized extent. Both domes of diaphragm are well outlined. CP angles are free.
This is ECG, 12-lead standardized ECG showing normal sinus rhythm. CBP showing moderate anemia with normal electrolytes and RFT. LFT is showing mild hypoproteinemia. CU is showing WBC of 4 per high power field with 2+ proteinuria. ABG is showing primary metabolic alkalosis with compensated respiratory acidosis. Ultrasound abdomen and pelvis is showing altered hepatic parenchymal echo texture with splenomegaly of 13 centimeters, which is normal in echo pattern, mild to moderate ascites with bilateral mild pleural effusion. 2D echo at the time of admission, no LV RWMA with EF of 60%, normal LV or RV function, decreased diastolic compliance, grade 1 LVDD, no MR, mild TR or PAH, RVSP of 33 mmHg, IVC is normal and collapsing, no PE, clots or vegetations. Treatment at the time of admission, IV fluids, 1 pint NS with multivitamin is given with injection ceftriaxone sulbactam 1.5 gram IV 12th hourly with injection atropine 1 mg IV 6th hourly and nebulizations with Foracort Nipsmart are given. ED. Day 1 to 5 patient had 1 to 2 fever spikes on day 3 and day 4. Blood pressure is maintained. Blood pressure is 140/90 mmHg. Pulse rate is 92 beats per minute with saturation of 98% with 6 liters O2. On respiratory system examination, bilateral air entry is present. Inspiratory creps are present in bilateral infrascapular areas. He is having GCS of E4, VT, M6, pupils for pinpoint. Same treatment was continued on day 1 and day 2, except injection doxy was added on day 2 and injection atropine 1 ml per hour infusion was started on day 3 along with injection glycopyrrolate 1 mg 8 hourly in view of increased secretions. Urine culture shows no growth, blood culture shows no growth. ENT referral was done on day 5 in view of bleeding from stoma, tracheostomy stoma site. On examination, blood stain secretions noted at stoma site with no active bleeding at the time of examination. Absent stay sutures on left side. Stoma site dressing and stay suturing was done. Advised proper care and avoid rigorous suctioning. Day 6, BP is maintained at 140 by 90 mmHg with pulse rate of 130 beats per minute and saturation dropped to BiPAP was put for him, and on BiPAP of FiO2 100%, saturation is 90%. On respiratory system examination, no air entry noted in left scapular and infrascapular areas. GCS dropped to E2, VT, M5. Pupils were mid-dilated, sluggishly reacting to light and planters were mute. Intermediate syndrome was suspected due to sudden deterioration. Injection pralidoxin 1 gram IV 8 hourly was added. Chest X-ray was advised. ABG is showing pH of 7.293 and PCO2 of 76, bicarb 29 and lactate of 0.9. Impression primary respiratory acidosis with secondary metabolic alkalosis. Chest X-ray which is done on day 6.
This is a frontal chest radiograph. Patient is in rotation. There is evidence of radiodense opacity occupying the entire left hemithorax, skewing the left dome of diaphragm and CP angle. All these signs could represent left lung collapse. Right side hemithorax is completely normal with the well outlined dome of diaphragm and CP angle. Central line noted. Tracheostomy noted in situ. Nasogastric tube noted in situ.
Your findings. What is your radiological opinion? That is what is needed.
Left lung collapse, sir. Due to
left lung is whitewashed lung with a total collapse because the tracheal component is cut off. If suppose if it is consolidation, beyond the trachea some segmental bronchial airgram seen. While air bronchogram is not seen the entire lung with the trachea in that, and suddenly left component is, that is a collapse. Both anterior
Pulmonology referral was done immediately in view of chest X-ray findings. X-ray shows homogeneous opacity in left upper, middle and lower zones. They advised for bronchoscopy and nebulizations with Mucinex 8 hourly with chest physiotherapy. Sputum culture revealed Klebsiella pneumoniae, which is sensitive only to cephalosporin sulbactam and polymyxin B. Bronchoscopy notes. Thick mucopurulent secretions are present in right, in left middle, lower, left upper, right middle, lower, left upper and lower lobe bronchus. Bronchial wastings were taken from left upper and lower lobe bronchi. Samples sent for AFP, CBNAT, KOH, culture sensitivity, gram stain. Procedure was uneventful. Bile fluid samples were sent. AFP negative, gram stain revealed gram negative bacilli. CBNAT was negative and negative for bile fluid is negative for fungal elements. This is post bronchoscopy chest X-ray which is taken 2 hours after the procedure.
Patient is in rotation. There is a evidence.
Bronchoscopy, they have removed all the impacted secretions. అది అక్కడ కొంచెం ఇంపాక్టెడ్ సెక్రేషన్స్ అని రాస్తే ఆడియన్స్ మీద ఇంపాక్ట్ బాగుండేది. The point here, your question is answered. You go back to the sudden deterioration component. Yeah, at this point, no. At this point, everything is going on well. Suddenly the pulse rate galloped and oxygen saturation swallowed up and down into the gutter by 90 on 100% at the BiPAP. And Clinical examination, fortunately done by the resident, or I don't know, it is retrospectively written or prospectively made out. If it is prospectively made out, I will pass him in the critical care, either DM or MD without any component. If it has made that there is no entry and correlated to the SpO2 and the pulse rate, that itself is a sign one lung is lost. And X-ray was taken. Therefore, for that component, I will praise all the team, advertently done, inadvertently done, or professionally done, whatever it is. I give you full credit. And why? It is nothing to do with the respiratory failure of organophosphorus, because pupils are dilated. If it is an organophosphorus respiratory failure, the things are not like this. It would have been not responsive to your ventilatory component from the beginning, with respiratory rate much lower. When there is a tachypnea, it is not due to an organophosphorus poisoning of respiratory failure, which is central in origin or peripheral in origin, masquerading. Both are different. Therefore, the sudden deterioration of hypoxia associated with no air entry is not diseasogenic but iatrogenic. That's what. And corroborated very well immediately with the X-ray. That doesn't solve the problem. Still, it can be a gross pneumonia. But the second X-ray should make the radiologist to comment very vigorously. Because the first X-ray you had collapse and consolidate. Collapse. Now you comment on this.
Compared to the previous X-ray,
how much comparison? If the comparison is time limit comparison, unlimited time comparison, that is one of the important crux of the problem.
After 2 hours of bronchoscopy.
In the history of realm of pulmonary medicine anywhere in the world, a pneumonic consolidation radiologically cannot be resolved within 2 hours. If it is disappearing in 2 hours, it is unequivocal evidence that it is collapse. తర్వాత consolidation down, secondary because we are still continuing that. That's all, nothing to discuss further. Which is evidently correlated. Clinical picture, radiological picture, bronchoscopic picture, and post-bronchoscopic recovery. All the 4 pillars have made it. It is an iatrogenic plug. Iatrogenic ante diseasogenic has no capacity. Why iatrogenic? You have done so many of ultra intubations, but you don't get it. No. This fellow had a weakness of the respiratory muscles. A simple malposition can bake in the presence of organophosphorus treated with atropine of noise. The secretions gets inspissated. It is not treated, you would have coughed out. No cough reflex much, and inspissation of secretions because of atropinization, we enhance it to 4 times per milligram. Along with that, that inspissation will make all the necessary things. Because he lost cough reflex, nor you have got the capacity to absorb because you have done not an endotracheal tube but on trachea, which is bleeding, adding to your agony. That's why we are presenting.
Pulmonology review was done post-procedure. They advised to add injection polymyxin B 5 lakh international units IV 12th hourly and to continue nebulizations and chest physiotherapy. This is the repeat chest X-ray done on day 7, 24 hours after the procedure.
After 24 hours of bronchoscopy, there is mild reduction of opacity in left hemithorax.
And with it all the word mild reduction, it is a total reduction of opacity.
Left dome of diaphragm is well outlined and left CP angle. Left CP angle is free. Rest of the findings remain same.
Day 7, patient had fever spikes on day 7. On examination, BP is 120 by 80 mmHg with 5 mics per hour NORAD. Pulse rate of about 92 beats per minute and saturation 98% with FiO2 60% connected to mechanical ventilator. Respiratory system bilateral inspiratory crepitations were present. GCS E4, VT, M6, pupils mid-dilated, sluggishly reacting to light. Injection cefepime 1 gram IV TID started on day 7 in place of cephalizone sulbactam. Injection PAM and doxy was stopped and same treatment continued. This is the repeat chest X-ray done on day 8, 48 hours after the procedure.
is it a residual patch or a new patch? That's the question, madam.
Reduction only, sir.
The secondary new patch, not the old patch. Or it is old patch.
BP is 100 by 70 mmHg, pulse rate is 82 beats per minute, saturation is maintained with oxygen 6 liters O2, respiratory system inspiratory crepes present in bilateral infrascapular areas, TCS is E4VTM6.
What is the interpretation of that as a resident of medicine? Past X-ray and this is the findings, not radiology, clinical. We had a decreased bed sounds adoption. Now we had a added sound, that means air is entering and ventilation is started.
Day 12 to day 15, patient had complaint of dry cough, chest physiotherapy continued, saturation is maintained with 4 liters O2, respiratory system inspiratory crepitations were present, injection atropine was stopped on day 15. Day 16 to day 19, tracheostomy tube removal was done on day 16. Patient started taking oral feeds. Saturation is maintained at 95% on room air. Injections ifipine stopped on day 16, rest same treatment continued. At the time of discharge, vitals were stable, saturations maintained on room air. He was tolerating oral feeds.
You should not write 16th day. You have to write the day of antibiotic because ifime is not given for 16 days.
He was tolerating oral feeds. He was discharged with tab Ebivin, bronchodilator, tab mucomix, multivitamin nebulization. Incentive spirometry was advised. Chest X-ray done at the time of discharge.
At the time of discharge, there is complete resolution of poisoning related opacity on left hemithorax and no superadded infection. Left dome of both domes of diaphragm are well outlined and both CP angles are free. Patient is in mild rotation. Rest of the findings are normal.
Final diagnosis, alleged history of chlorpyrifos 20% with alcohol with intention of self-harm.
He had an intention of self-harm. He studied very well, like a resident. Therefore, pyrifos will not kill so fast. Therefore, he took his component of alcohol and studied, and both will make the pyrifos to stay for a long time. Because when once alcohol is given, organophosphorus compounds of lipid solubility increases to deposit in the lipid store, and the prolongation of OP poisoning duration will become very long. If organophosphorus taken on empty stomach with acid, the percentage is 30 to 40%. When you take with alcohol miscible, it goes and deposits very fast in the lipid. The moment it is repaid, your treatment will not work, it releases slowly. As long as it releases, you have to continue the atropine and bam. It may be 1, 2, 3, done it for 6 weeks in a anesthesia doctor who committed that. And on the 6th week, we have to do the things and all sorts of compounds. Because organophosphorus mentioned lipophilic going, the prognosis is bad unless we continue the treatment of release.
They had thumbs up also.
They
had thumbs up also.
Yeah, thumbs up contains sugar which makes both to be absorbed very fast, dissolved organophosphorus. Because sugar across the intestinal epithelium goes without any enzymes. When it is a gradient dependent along with some other like our alcohol.
Why PAM was started late? You should have given the specific antidote rather than
He
appropriate.
was already outside.
He was working himself for 7 days.
6 days he is outside. No. They stopped it. He was in 7 days incubation and then they made incubation and tracheostomy and then sent him because his pulse is weakened and he is also weak. At the weekend.
Status post tracheostomy, left lung atelectasis or collapse secondary to impaction of mucus plugs, status post bronchoalveolar lavage. Summary, in cases of OP poisoning commonly in the ICU settings, when there is sudden deterioration in patient saturation after a week or 10 days of admission, it is commonly presumed to be because of respiratory muscle paralysis secondary to intermediate syndrome. But as there is significant bronchoria in OP poisoning cases, there is high probability of mucus plug impaction leading to atelectasis or collapse of lung. In our case, there was collapse of left lung due to impaction of mucus plugs in the bronchus. Thank you.
Thank you. You have done something last slide wrong. One component. Significant bronchoria will not cause thing. It is insignificant. Bronchoria is corrected there outside with a good amount of atropine. But they never bothered to give hydration. And it is further added to the agony and pepper onto the injury. Thank you. Any questions?